All right. Good morning, everyone. Welcome to another AMSSM Sports Ultrasound case series. We're getting started here with our fall series, where our faculty presenters take over, and that will run about every other week through the rest of the fall before we switch once again to the fellow series in the spring. And so today I have the pleasure to introduce Dr. Stephen Schaaf. Dr. Schaaf has taken over running this case series, and we're happy to have him presenting as we get kicked off into the fall portion of things. We've been off for a little while with the transition of the academic year. And so Dr. Schaaf is an assistant professor in the Department of Physical Medicine Rehab and Orthopedic Surgery at Vanderbilt. He completed his PM&R residency and sports medicine fellowship at University of Pittsburgh Medical Center, and he's been at Vanderbilt since 2019. He brings a wealth of knowledge with sports ultrasound. He's been doing a great job running this series, and we're excited to have him presenting on Flexor Pollicis Longus Tenosynovitis.
All right. Well, thank you so much for the introduction there, Brennan. I really appreciate it, and super excited to go ahead and get started with the faculty portion of presentations this year. And as you had mentioned, that will be going every 2 weeks through December. We have a great lineup of attendings and topics, and I'm fortunate enough to kind of start with that today. So we're going to be talking about a very interesting and fun case about Flexor Pollicis Longus Tenosynovitis. So a wrist and hand case. And as Brenton mentioned, I'm currently at the Vanderbilt University Medical Center working with both the Department of PM&R as well as orthopedics, and really helping to run the ultrasound education for the sports medicine fellows as well as on the PM&R residents here. So for this talk, I don't have any financial or other conflicts of interest to report. And so just the general outline for these presentations is that we'll be really kind of following a case format. Then we'll kind of go into scan considerations for the wrist and hand in the specific case, then going through the protocol structures that we're going to want to look at for a comprehensive examination. Then we'll actually be going through the images themselves, and then finally going over the report from those images, and lastly, just have a discussion about the finalization of the case. And so the case that we'll be discussing today involved a 42-year-old right-hand dominant male manual laborer who was referred for acute right volar wrist pain and swelling. And so to give a little bit more background, so these symptoms actually started around 6 weeks prior with no inciting trauma. Since this time, the patient really had fairly persistent volar forearm, wrist, and hand swelling that worsened, especially with finger flexion activity. The main past medical history for this patient was significant for a one-time flare-up of gout. And up to this point, he had been seen both in the ER as well as subsequently by orthopedic hand surgery. On physical exam, it was just really notable for fairly generalized tenderness and swelling along the volar forearm, wrist, and hand. But this really wasn't noted for really much skin warmth or erythema. And then most notably from kind of really special testing and just pertinent positives is that he really had pain reproduction just with active finger flexion as well as in passive extension of his fingers. So as I mentioned, he had already been to the ER as well as an orthopedic hand surgery. So he'd already had some imaging coming into this case. And so he did have a right wrist x-ray that demonstrated no osseous abnormalities. But actually, when he was in the ER, he did have a CT right wrist with and without contrast. And this interestingly had noted that there was a potential ventral abscess tracking from the distal aspect of the forearm along the flexor tendon sheath into the palm. However, there was no evidence of osteomyelitis. And so once again, we can kind of see the CT images here kind of demonstrating, see if I can get a pointer real fast. Just demonstrating. Brennan, are you able to see this?
Yes, I can.
Okay, so just kind of demonstrating the area where there was concern for potential abscess in that region. But subsequently, after the patient was seen by orthopedic hand surgery, it just really didn't seem to kind of fit the picture that this was potentially related to an abscess and specifically an infection. And so then this patient was subsequently sent to our clinic for further evaluation, specifically with ultrasound. And so the main thing here then is, once again, is ultrasound going to be helpful, in this case? And what I'd say specifically for this, when we're looking at a fluid collection, is ultrasound can be extremely helpful to kind of further differentiate simple versus complex fluid, especially for tenosynovitis, which was shown on the CT scan, as well as then further evaluate for synovial hypertrophy. And obviously that's highlighting the diagnostic utility of ultrasound, but obviously there is some interventional utility as well too, that it can assist with fluid aspiration. Specifically for doing the wrist and hand evaluation with ultrasound. Typically for this, we're going to be using a high frequency transducer. And a lot of the time I'll be kind of going back and forth between using a linear array transducer, as well as then a small footprint, sometimes what we'll call then kind of that hockey stick transducer, depending on if we have those available at the clinic, and kind of going back and forth using those to kind of look at pertinent pathology. And typically for this scan, then I'll be having the patient in a supine position with the wrist in supination. And so for the protocol for the volar wrist, this is kind of the standard protocol that I follow that has kind of been mentioned by AMSSM as well too in their curriculum. And this is kind of the routine structures that I want to make sure to go over, especially in the volar wrist region. And so typically I'm going to start out with the radiocarpal joint. I think this is just a really good bony landmark to kind of start with and get yourself oriented. And in addition, when we're kind of looking for any type of potential inflammatory processes and things like that, this can always be helpful to kind of evaluate, especially for effusion or synovial hypertrophy. Then we'll be kind of going through the rest of the soft tissue structures in this area, then looking at the median nerve, flexor retinaculum, then the radial artery, and then a lot of the flexor tendons in this region. And then finally moving more ulnarly, taking a look at the ulnar nerve as well as then artery. And so then this is kind of the typical standardized protocol that I'll want to go through for the volar wrist, just to make sure that you're not missing any pathology and doing a comprehensive exam for this region. And so, as I mentioned, I kind of start out at the radiocarpal joint for my protocol for the ultrasound for this region. And as I mentioned, one reason for that is it's just a really good bony landmark that you can find the scaphoid. And so obviously for this, we're going to kind of see the bony contour of the scaphoid, which is going to be along the radial aspect and most superficial to this region. I think this is a very good, kind of quick way to orient yourself, especially as you get down to the carpal tunnel area and the radiocarpal joint to first orient yourself. So that's usually kind of what I'll use as my home base for this region, which I think can always be helpful, especially sometimes in these complex scans, just to make sure that you're kind of at least getting to initial area where you feel comfortable looking at these structures. From that scaphoid then, the typical view that I'll want to see for the radiocarpal joint is then actually flipping into long axis. And so for all the images today, we'll have the corresponding ultrasound image, but as well too then the kind of transducer orientation for each of these images as well. So once again, now we're going to be in a long axis view, taking a look at that radiocarpal joint. And what we're going to be seeing here right on the screen will be proximal as that radius. And then as we get to this area, then we see the true radiocarpal joint along the volar aspect of the wrist. And then we're going to see then that kind of bony contour of the scaphoid, which is kind of described as a peanut shape. And in this area, we weren't seeing any kind of pertinent pathology such as effusion, cortical irregularities, or synovial hypertrophy. Next, we'll move on to the flexor retinaculum. Obviously, this is going to be more of a concern, especially if the patients have had surgery like carpal tunnel release, things like that to look if that's been completely released or any abnormalities associated with that, which the patient did not have. So in this case, the Flexor retinaculum looked normal in this case. Typically, then you can look at both of the carpal tunnel inlet and outlet for this as well too. And obviously, we're just have a still image of this at the carpal tunnel inlet involving the scaphoid and then going all the way over to the pisiform at that area. Next, then we'll evaluate the median nerve. Typically for this, I'll be scanning all the way from the kind of forearm and the pronator quadratus, then to the carpal tunnel. And typically for this, then we'll be doing comparison measurements at both those locations, and then just looking for any nerve abnormalities as we're scanning along that area. And so the first area that we're taking a look at is once again the median nerve at the pronator quadratus. And so this is going to be in the distal forearm area for this. And then we can kind of see that pronator quadratus scanning from the or transversing from the radius then to the ulna at this location. And then once again, then we see the median nerve here where we're doing a measurement, and then this ultimately was 6 millimeters in cross-sectional area for the measurement at the pronator quadratus. Then we'll go down distally once again to that carpal tunnel inlet, and once again where we're seeing the scaphoid and pisiform, a flexor retinaculum go over on top, and once again doing an additional measurement at this area where the median nerve was 6 millimeters in cross-sectional area. So once again demonstrating kind of no difference between those two measurements at that area, and nor when we were kind of scanning this area did we see any specific enlargement or loss of fascicular appearance. But always important to take a look at this in a long axis view as well too. Sometimes this can be specifically helpful for looking at notching or compression, especially as you get to the flexor retinaculum or that transverse carpal ligament. But once again, we see kind of the median nerve sitting on top here of the flexor tendons and not seeing any changing contour of the median nerve at that area. Next, we'll move along to the radiovasculature and specifically the radial artery. I think this can be helpful to look at because on occasion you can have soft tissue masses associated with the radial artery, such as like a pseudoaneurysm, as well as it is very common to get ganglion cysts in this area as well too. But in this, obviously on color Doppler, we're identifying the radial artery in this region and not seeing any abnormalities associated with it. Next, the first flexor tendon that we're going to take a look at is going to be the flexor carpi radialis longus tendon. And so the easiest way to find this, once again, is identifying the scaphoid, and this is then going to be just superficial to the scaphoid at that region. And for the FCR at this location, we weren't seeing any major abnormalities such as tears or tenosynovitis. But once again, always important to look at these tendons in two orthogonal planes. And so we're taking a look at this now in a long axis view. And once again, we're seeing the FCR tendon as it's going from proximal to distal, and then we're kind of losing some of the tendon here as it's going to kind of obliquely dive past the scaphoid onto its insertion of the distally at the metacarpals at that region. The next flexor tendon that we'll take a look at is going to be the flexor pollicis longus tendon. And so this we're taking a look at kind of at the distal forearm as well as then the wrist. And right away, when we're taking a look at this tendon, especially compared to the FCR, we can see that there is some hypoechoic to isoechoic distension of the tendon sheath. In addition, there is kind of then some kind of isoechoic synovial hypertrophy in this region. Sometimes when you get to those flexor tendons within the carpal tunnel, especially as well as the distal forearm, I think sometimes it can be hard to differentiate, FPL versus then the rest of the FDS and FP tendons. I think one easy way to do this is obviously activation of those tendons. And so this is just a video demonstrating that the patient initially is going to be flexing his thumb at this area, which is demonstrating movement of the FPL tendon that we can easily differentiate. And then really right at the end of this video, then the patient starts to flex the rest of the fingers throughout the hand, which is demonstrating those movements. But this is a quick way that you can kind of easily differentiate when you're trying to kind of interrogate each of these tendons separately. is going to be your video clip of that FPL tendon, really focusing on scanning from distal or from proximal to distal along that forearm, just right as we're getting to the carpal tunnel inlet. And once again, this is demonstrating that really along the FPL tendon, there's going to be that hypoechoic and anechoic or hypoechoic and isoechoic distension of the tendon sheath, as well as then some synovial hypertrophy within that tendon sheath region, but ultimately no significant tendon tears we're seeing. Then we actually wanted to continue to follow this, distally, just to make sure that you had the integrity of that FPL tendon. There were not any significant tears. And so that's key in some of these, because obviously, we're doing a volar wrist scan, but in some of these cases, even going down into the hand as well as the fingers, just to make sure you do a comprehensive evaluation of that entire tendon, just because sometimes the pathology can truly be distal to this area. And once again, even when we're getting down then now into the thenar area of the hand, we're still seeing that kind of hypoechoic to isoechoic distension of the FPL tendon sheath at this region. And once again, this is now going to be a linear video clip that as we're scanning through that hand and the thenar musculature, that you can continue to see that distension of the tendon sheath, as well as then the synovial hypertrophy at that region, scanning from proximal to distal at this area. As I mentioned, always important to look in those two orthogonal planes. So now this is going to be a long axis view of that FPL tendon, where once again, we're just confirming findings of that hypoechoic to isoechoic distension of the tendon sheath, along with synovial hypertrophy of the tendon sheath at that region. And so two things I really want to highlight is that for further evaluation, when you see any type of tenosynovitis, especially if you're concerned for synovial hypertrophy, is doing the addition of color Doppler at this area that can demonstrate hyperemia or vascularization to that area, which can be more of an indication that this is truly synovial hypertrophy rather than just like an inflammatory tenosynovitis at this area. And so in this case, we then use the color Doppler, and as we can clearly see, this patient was having vascularization or hyperemia to the FPL tendon sheath. Furthermore, another helpful way, I think, to differentiate when you're looking at tenosynovitis, especially if you're concerned for simple versus complex fluid, as well as then synovial hypertrophy, is going to be looking at the compressibility of the tendon sheath fluid. And so this is a video demonstrating that we're putting transducer pressure directly over that FPL tendon and basically looking to see if that fluid is compressible. And in this case, there is mild compressibility, but ultimately some of the isoechoic area we're not able to fully compress, which is going to be more indicative of true synovial hypertrophy rather than just complex fluid at this location. And then this is going to be a furthermore video of looking at that compressibility and long axis. So once again, we do have some mild compressibility, more of the kind of hypoechoic fluid, but definitely some of the isoechoic fluid, as well as in material with the synovial hypertrophy, we can see is truly not compressible in this long axis video. All right, so that was for the FPL tendon. Now we'll move on to the FDP and FDS tendons. And so this is initially taking a look at those tendons at the wrist. And so to not the same degree, but we still are seeing some tendon sheath distension involving these tendons with kind of hypoechoic to more primarily isoechoic fluid, along with some synovial hypertrophy at this area. And so this is going to be a little bit more apparent as we're kind of doing a video, once again, going from proximal to distal at this location, where you can see kind of a little clefts of fluid. And obviously then this kind of gets a little bit more compressed as we're going distally, as those tendons get more compact as you go towards the carpal tunnel at that region. But once again, important to kind of interrogate these tendons even as we're going distally. So now as we follow one of the separate FDS and FDP tendons to the fingers. I think this was then for the fourth digit. We're continuing to see, once again, even distally, some tendon sheath distension with hypoechoic to isoechoic fluid with some synovial hypertrophy involving those tendons at this area. And once again, this is now going to be a video clip where we're following these tendons to the second through fourth digits from proximal to distal at this location. And I think really the one to kind of highlight at this area is that you really see that kind of tendon sheath distension involving the fourth digit here going to that ring finger, where you can see those findings. All right, furthermore, then for the scan, we'll take a look at the Pollicis Longus tendon, which of course is going to be just superficial to the flexor retinaculum, and we weren't seeing any abnormalities for this at this location. And then lastly, the most ulnar flexor tendon, the flexor carpi ulnaris. We'll take a look at this as it's kind of going over the pisiform at this location near Guillen's canal. And once again, we're not seeing any major tears or tenosynovitis at this area. And then lastly, we'll be taking a look at the ulnar nerve at Guillen's canal. And so we can see that at this location next to the ulnar artery. Did do a measurement at the ulnar nerve at this area, which was 4 millimeters in cross-sectional area, and just really didn't see any major nerve abnormalities in this region. And once again, then lastly, just taking a look at the ulnar artery. As we had mentioned for the radial artery, on occasion, you can have masses associated with this, such as pseudoaneurysm, or ganglion cysts in this area, which aren't as common as the radial side, but still something to kind of take a look at if you're concerned about any swelling in the wrist area. And so that concludes the images that we took from this case. We'll now kind of go into the report and the components that you need to put in for this. And so as we mentioned, this was a complete diagnostic ultrasound of the right volar wrist. The indications for this was that it was acute right wrist pain and swelling. From a technical aspect, we mentioned the transducer that we used, which was a 13.5 megahertz linear array transducer for this scan. And then, of course, then now go into the findings and taking a look at the protocol of structures that we took a look at. And so first and foremost was that radiocarpal joint, where we didn't see any major cortical irregularities, effusion, or synovial hypertrophy. Next, taking a look at that median nerve and flexor retinaculum, as we had mentioned, just where we scanned from, which was the pronator quadratus to the carpal tunnel, and then the measurements that we took, that there was no cross-sectional difference between those areas, which sometimes can be indicative of median nerve, enlargement at that area and potential carpal tunnel syndrome. But once again, we weren't seeing any median nerve abnormalities. Now getting into the flexor tendons, as we mentioned, the first that we took a look at was the FCR, which did not have any tears or tenosynovitis. But now kind of the main pertinent findings from the scan and the images that we saw was really involving the Flexor Pollicis Longus tendon, where we did see tendon sheath distension with hypoechoic and isoechoic fluid that was mildly compressible, and that there was tendon sheath synovial hypertrophy present with increased vascular flow on color Doppler, but ultimately no tendon tears were seen throughout this region, and the patient was noted to have a sonopalpation tenderness over this area. Similar findings within the FDP as well as in the FDS tendons, as we had seen on those images, but just a little bit less degree as we saw with the FPL tendon. And then kind of following through the rest of the report, Pollicis Longus tendon did not demonstrate any abnormalities, and same with the FCU. And then lastly, looking at the ulnar nerve as well as in the ulnar artery at Guillen's canal, we didn't see any abnormalities. And as we had mentioned, the ulnar nerve was measured 4 millimeters squared in cross-sectional area. And then lastly, just had mentioned within the report that taking a look at the soft tissues in the area, especially along the radial and ulnar wrist, that we weren't seeing any ganglion cysts. And so ultimately the conclusion then for this case is that we saw FPL, FDP, and FDS tenosynovitis with complex fluid and synovial hypertrophy. And so kind of conclude this case a little bit, once again, really not trying to highlight the interventional aspects, but I think it does help to provide kind of just a conclusion to this case, is that we actually did perform an ultrasound guided right FPL tendon sheath aspiration for this patient to be able to perform synovial fluid analysis. This then is going to be the synovial fluid analysis for this patient. And so the fluid came back as slightly cloudy. We then see that there is an elevated white count to around 10,000, and this was predominantly with polynuclear cells, 97%, as well as then with some red blood cells present, but ultimately did not demonstrate any crystals, and then on culture did not grow any bacteria. And so ultimately for this case, I think then the synovial fluid analysis was pretty confirmatory for this being a true inflammatory tenosynovitis along with synovial hypertrophy. Ultimately, this patient was seen back by the orthopedic hand surgery team. They were treated with a course of methylprednisolone successfully to this point. And so really kind of the key points I just want to mention and potentially up for a discussion is just really highlighting simple versus complex tendon sheath fluid. Really the main thing to kind of differentiate this is that complex fluid is not going to be anechoic. Typically for this, it might be more slightly hypoechoic to isoechoic or that mixed echogenicity. If you're seeing that, that's going to be more indicative of complex fluid, which potentially is either going to be inflammatory or infectious. Another thing to kind of highlight is looking at the complex fluid versus synovial hypertrophy. As I mentioned, the two things that kind of be helpful to differentiate this is looking at compressibility as well as then vascular flow and color Doppler. And so the main thing is that typical true synovial hypertrophy is not going to be compressible, as well as it's going to demonstrate vascular flow on that color Doppler, whereas the complex fluid, you'll at least have some compressibility usually to that fluid. And on occasion, it still can demonstrate the vascular flow, but really the differentiating factor is going to be that compressibility. And then lastly, I mean, obviously, we're really highlighting the diagnostic utility of ultrasound here, but really interventionally ultrasound guided tendon sheath aspiration can also be very helpful to assist in the diagnosis of these cases of inflammatory tenosynovitis. And so I think that is it as far as the presentation. I now will kind of open it up for any questions or comments anyone might have.
Yeah, Stephen, this is Doug Hoffman. What a great start to the season, the K-Series seasons. I mean, he really demonstrated nicely your protocol, sticking to the protocol and methodically going through all the structures of the volar wrist. And the images were right on and stuff. So this, I mean, great presentation. Funny, because I had a exactly similar case this week, except it was the FPL, the FCR, and only one of the FDS tendon sheaths. And so in my mind, this is kind of the classic presentation from my experience of an inflammatory arthritis. And the reason why I say that is it involves more than one tendon sheath. Sometimes when you just get one tendon sheath, it can be a little bit harder to jump right away to an inflammatory arthritis. But once you get more than one tendon sheath involved or one area involved in the wrist and hand, then I think that the likelihood that this is an inflammatory arthritis is pretty high. I actually probably would have said in my report, or what I put in my report is exactly what you have, but then I would say suggestive of an inflammatory arthritis. And I think that's reasonable to put in. It's not wrong not to put it in and a sort of dealer's choice, but oftentimes when I see this pattern, I will say suggestive of an inflammatory arthritis. I'm just going to highlight a couple of things you said. Just, because you use the word tenosynovitis quite a bit, and I think it's worth mentioning. For me, at least, I use the term tenosynovitis exactly like you do. So for me, tenosynovitis means inflammation, true inflammation of a tendon, which mostly involves a tendon sheath, can involve actually the tendon fibers themselves, versus tendinosis. So let's say you're scanning, you see some ratty tendon of let's say the, ECU tendon, that's a tendinosis. But when you see what you have presented, I think that is a true tenosynovitis. And tenosynovitis then is defined as exactly what you're showing with vascularity. And the same with synovitis. So synovitis would be synovial hypertrophy with vascularity. So I think those terms are important to establish because oftentimes with MR readings, any fluid within the tendon sheath is read as tenosynovitis. And in my mind, at least, truly that's not a tenosynovitis because we haven't proved that it is inflammatory. Um, Going back, my risk protocol is a little bit different. It would be the same with yours, but I start all my risks on the dorsal aspect, and I do 3 images, long axis over the dorsal recesses. If they're abnormal, I do a short axis, and also do it's an anatomic transverse or a short axis view of the distal radial ulnar joint. And I do that for exactly this reason is, when I can't tell you how many people I've picked up in inflammatory arthritis doing a carpal tunnel evaluation. And so in this case, I probably would have also, gone and looked at the dorsal recesses. And in fact, our sonographers are trained to, when they see something like this, to sort of convert this to what we call our rheumatology protocol. So we would also, and you don't necessarily need to, save all the images or document that, but I would have probably documented the dorsal recesses, the distal radial ulnar joint. We would probably also have looked at the MCP joints and just look for signs of synovitis. And again, if we may not save all those images, and also just quickly look at the dorsal compartments, particularly the 6th dorsal compartment, which is the most compartment that we see inflammatory changes, because I think this person probably has an inflammatory arthritis. And so that's just another, approach in this situation. So again, when I do a volar wrist exam, I usually start with those dorsal images. It takes me about 30 seconds if they're normal. And in this case, it could have had some pertinent information. But that's just, one way to approach it. I mean, your protocol is pretty complete. And, you did look at the volar radial carpal joint, which has a lot of redundancy. So if there's an effusion or synovitis, you're going to see it in that volar recess. And then just the last quick comment, it was interesting on your images of Guillen's canal, there's an accessory abductor digiti minimi muscle there. And I just point that out for people that are new to this and may not recognize it, but it was a really nice picture there of the abductor digiti minimi muscle, which is a fairly common accessory muscle that we see. It can be a cause of Guillen's canal syndrome, but I mean, I can't, I can't quote a figure of how often they're seen. I don't know if ultrasound studies have been done, but I bet I see those, 5 to 10% of the time on exams.
Yeah, I was actually, I knew that you were going to mention that dog at first. I knew it. I didn't know whether to mention it in the protocol. I think it was one of those that if it was pertinent to the pathology, I mean, sometimes I'll mention it, but yeah, I think when looking into literature for this, they actually said it's up to 24% of individuals will have the accessory abductor digiti minimi. And so obviously I think that's a little high, but I think it just depends on, how many of these that you're doing. But yeah, I think this was definitely highlighted that as well too.
Yeah. So, I mean, this is just a great example. Probably my most common diagnostic exam right now is the carpal tunnel, just based on my practice right now. So, I do a lot of wrist and I see this not that unoften in the sense that we have an unsuspected tenosynovitis. And so, even for my volar wrist protocol, I do exactly what you do is I look at the FCR, and I methodically go through the tendons as well as just a couple of those dorsal wrist structures. Because again, I mean, every once in a while, probably once every couple months, I pick up an inflammatory arthritis, and inflammatory arthritis can be a cause of carpal tunnel syndrome. So they're presenting this carpal tunnel syndrome, and it's great to look for secondary causes. So yeah.
No, Doug, you bring up a really good point because actually in this case, that was one of the concerns is that he was getting carpal tunnel syndrome associated with that. And so that's why one reason they were kind of wanting the ultrasound as well too, to kind of evaluate that further. And I definitely completely agree with your points of the dorsal wrist, taking a look at that, especially for effusion or, you know, irregularities, looking for an inflammatory arthritis, you know, at that area. That was one of those that you go back through these, and sometimes then when you're doing the presentation, you're like, oh geez, like that definitely would have been helpful. And honestly, I think this case, like, you know, we start to get very comfortable for a lot of the musculoskeletal etiologies. But as soon as it kind of gets out of that area, and I think for the wrist and hand, you know, two of those are going to be when you start to see like an inflammatory arthritis condition, as well as like a soft tissue mass. You know, that's where we get, you know, a little bit uncomfortable, you know, when we're, you know, initially just looking at musculoskeletal, you know, conditions and things like that. And honestly, for a lot of the inflammatory arthritis, you know, conditions, we have a really good rheumatologist here, Dr. Aaron Chu, that I'm learning quite a bit from, as far as then protocols specifically, you know, for the wrist and hand, taking a look at these inflammatory arthritis conditions. And as you had noted, definitely very important to kind of take a look at those if you're doing a comprehensive exam for those specifically, to be looking at the dorsal wrist, as well as then you had mentioned the metacarpals at that region.
Yeah, and again, as you started your presentation, you know, this is such a powerful tool. I think that patient that I saw this week, the flexor tendon tenosynovitis was actually related to psoriatic arthritis. And I've seen a very similar presentation to the one you presented, but maybe it might be one or just two tendon sheaths, and it was gout. And sometimes you see that little echogenic dots in the tendon sheath, but it can really surprise you, the etiologies of this.
Yeah, I guess, Doug, the one thing yeah, we didn't get to a definitive, you know, diagnosis with this patient. I think if they have a flare-up of symptoms, they're going to be referred to rheumatology probably for further evaluation and testing. But since this was kind of a one-time, you know, episode for them, and they were treated successfully. But one thing was maybe potential diagnosis of PBNS for this patient. I didn't
Interesting.
know how. I mean, that was talking with the kind of the hand surgeon a little bit. I think that's potentially more what they were kind of leaning towards, rather than just like an inflammatory arthritis. But once again, some of these are just really hard because it's a one-time episode, and then, you know, they don't get any further testing. And so in this case, that was just kind of the one thing that I was still kind of, you know, wondering about it, if that would be the case as well too.
What did you think, you know, going back to that CT scan, and that potential fluid pocket, did you think that was from the tendon sheaths of the FPL and then the adjacent FDSs?
Yeah.
Uh-huh.
Yeah. Yeah. Let me see if I can pull those back up. Yeah, I think yeah, just in this area, I think it was just really hard to differentiate, just because once you get the flexor tendons in that region, you just see a bunch of fluid that's kind of all within that area, and obviously get concerned any time with the history and everything that's going to be more infectious. But obviously that was the one reason to kind of further get the ultrasound, just because it really didn't seem to be matching up with that.
Right. I think the CT scan is probably reflecting that it seemed to me at the level of the wrist, at least, that the flexor tendon sheaths communicated from the FPL and the FDSs. So probably created this larger pocket. Great jobs. Nice presentation. I mean, people who do a lot of wrist and hand are going to see this. And this is exactly how it's done, is just to methodically go through and you know, assess each tendon, and again, you know, potentially assess joints. So yeah, really great start.
Well, really appreciate it. I guess I'll just open it up for anyone else that has any other questions or comments.
Stephen, that was fantastic. You guys kind of covered the couple notes I had written down, but that's just a great example of, you know, widening our differential diagnosis from our, you know, traditional sports sort of conditions to kind of, you know, involving the medical side of musculoskeletal, you know, problems, and I have nothing else to add.
All right. Well, that will conclude today's talk. So as we had mentioned, we'll be now following up for the rest of the fall with faculty presentations every 2 weeks. And I think in 2 weeks, the next presentation is going to be involving a finger case with a mallet finger. So thanks again for everyone tuning on. We'll see you again in 2 weeks.